Hello, I'm Dr. Cheryl Olson. Today I'd like to talk a little bit about hernias, abdominal hernias in particular. Many people come to see me in the office and may or may not have an abdominal hernia. Abdominal hernias can occur at a variety of locations. The most common is an umbilical hernia, which occurs obviously at your umbilicus, your belly button, and that's a common place now for incisional hernias as well, because we use the umbilicus as a port of entry, and so sometimes that develops into an umbilical hernia. Another word that can be used to describe a hernia is ventral hernia, and that is often a hernia somewhere in the midline of your abdomen, which can occur on its own. A weakness develops and then tissue pushes through. There's another condition known as diastasis recti, which is often mistaken for a ventral hernia. People notice that when they sit up, they see this bulging out, but it's an elongated bulging, and then when they stand up, it oftentimes goes away. Or when they're laying flat, there's nothing there either. And so that's a diastasis recti, and basically what happens is your rectus muscles have little coatings over them, makes a little pack, and then they meet in the midline, and so when you get a diastasis recti, that midline fascia stretches, and so it'll bow out, but there's not a hole there. When there's a true hernia, there's an opening in the fascia, and so that's what causes or allows tissue to push through. But if it's that diastasis, it's just a stretching, and you just see the bowing, but it's a temporary thing, and of no concern about there being incarceration, strangulation, etc. So I just wanted to clarify that. So if you have one of those types of hernias, you can maybe help to differentiate it with your doctor. Obviously, hernias that become symptomatic, causing pain, etc., probably need to be fixed. Hernias don't go away on their own. And so what the natural history is that they gradually get larger or become more problematic. If the tissue that's coming through intermittently comes out and gets stuck, that's called an incarceration. And that's an urgent need to have surgery. Many patients come to the emergency room and end up having surgery that day or the following day if we can manage to get it reduced. More commonly, hernias come from an old incision. So a patient has surgery for whatever reason and the incision is closed, but over time the repair of that area breaks down, and that can cause a hernia. And then those need to be fixed as well. So one of the things I wanted to just introduce is the numerous options that we have to repair hernias and kind of how we do that and the philosophy behind that. So obviously we do open surgery. Sometimes very large hernias need to be repaired in an open manner where we can really dissect a lot of the tissue, get very firm fixation for mesh, and repair the big hernias that way. The other approach that I like is the robotic hernia approach. When hernias are a bit smaller and a little easier to manage, we can go in a minimally invasive way and repair the hernia, much like we would do open, also with mesh, but repair the actual fascia and then reinforce that with mesh. Sometimes the hernias are very small, and it's better just to use a small incision directly involving the hernia and repair it with a little mesh, and then the patient's recovery is also fairly quick. So one of the questions that comes up often too is concerns about mesh. There's a lot in the media, certainly online, about mesh and problems with mesh, and there have been meshes in the past that have been problematic. Most of the mesh we use, or the only mesh we use, have not been recalled, certainly have a very good track record in our practice. One of the meshes we use commonly is called a ProGrip mesh, and it has some little Velcro tabs on it that help to secure the mesh when we initially place it. Then those little Velcro tabs actually dissolve. So that's one way that we can avoid some of the problems that can occur with mesh. Mesh can move, and so more often than not we have to keep it in place or fix it. One of the reasons I like using robotic surgery is that there's a technique where you create a little bit smaller space that sort of encloses the mesh and doesn't allow it to move as much as it could. So those are just some of the concepts and thoughts about ventral or incisional hernias, how and why we repair them, when to repair them, and if you'd like more information, look us up on the website or make an appointment to come to the office and have a consultation.